where electricity cannot short or bypass across that central obstacle. So in re-entry, what happens is electricity or current flows down one pathway, then the other pathway, which is slower, it takes time for it to go back up. And then by the time it turns around and comes back to the first pathway, because it took forever to get back up, this pathway says, all right, come on down. And so it accepts it. And then you go round and round and you form a loop. And that is classic re-entry. And typical examples of re-entry tachycardia are AVRT, which is atrioventricular reentrant tachycardia, AV node reentry, which is AV nodal reentrant tachycardia, IART or intraatrial tachycardia, also known as atrial flutter, or sometimes scar-related ventricular tachycardia. And the way I think about it is reentry is almost like a dog chasing its tail. The dog will go round and round till the dog is able to bite the tail, then it hurts, then it stops. So if electricity collides, or at some point one of the pathway properties change, that reentry circuit will stop. Classic characteristics are rate is typically regular. You can start and stop this tachycardia reliably with pacing. And if you cardiovert someone who's in a reentrant tachycardia, that is usually effective. All right, so that's the first type of tachyarrhythmia. The second mechanism is what we call automaticity. So this is an automatic focus which has a mind of its own. So the rate is typically variable. It is not started or stopped with pacing, meaning, for example, if a patient has an automatic focus that's going at 200 beats per minute, and you pace someone at 250 beats a minute for 10 seconds and you come off, it doesn't do anything to the automatic focus. As soon as you stop pacing, that focus will wake up again and it'll start firing at 200 beats a minute again. And you can cardiovert them. There's a pretty good chance that focus will suppress for a few seconds and come right back. So those are the typical characteristics of an automatic tachycardia. Contrast that with the reentrant tachycardia we just looked at. And some of the examples are ectopic atrial tachycardia, junctional ectopic tachycardia, accelerated idioventricular rhythm, accelerated junctional rhythm, and VT. And the third mechanism is triggered activity. Conceptually, this is the hardest to understand, but briefly and to simplify it, it has characteristics of both a reentrant tachycardia and an automatic tachycardia. So the rate is variable, and you can see there's a lot of hedging on this slide. So with pacing, you can often initiate and terminate it with pacing, and cardioversion will usually terminate it. And again, you can have all of the tachycardias that we talked about, typically ectopic atrial tachycardias that can have features of triggered activity. Okay. So I try to keep things simple, at least in my head. And every time I look at an EKG in a patient with a tachyarrhythmia, there are a few steps that I go through in my mind. And this is a simplified algorithm for EKG analysis that we developed. And I want to go over this with you. So we get an EKG, 12-lead EKG or a rhythm strip, and the patient's in tachycardia for his or her age. So what I'm looking at is my QRS complex, is it narrow or usual? Now I want to introduce the concept of usual complex tachycardia, or what we call typical complex tachycardia. For example, let's take an example of a 5-month-old. A 5-month-old had a VSD repair. It's very common for that patient to have a right bundle branch block after VSD repair. If that patient goes into SVT, the QRS is not going to look narrow. The QRS will look wide because he already has a bundle branch block. However, for that patient, it is his usual QRS complex. It is what his QRS complex usually looks like in baseline. So for him, a wide complex tachycardia is actually a narrow or a usual complex tachycardia. It is not wide for the patient. And that is a very important concept that I want to impress upon you today. All right, so this patient has a narrow or a usual complex QRS. The biggest thing we look at in EP is what is the relationship of the atrium to the ventricle, or the P waves to the QRS. So A throughout the presentation represents atrium, V represents ventricle. So if in this case we have more A's than V's on the EKG, it's usually one of these things. So you're probably looking at an atrial tachycardia, whether it's atrial flutter, atrial fib, or an automatic atrial tachycardia. If you have A's that are equal to V's, then you're probably looking at sinus tachycardia or some sort of reentrant mechanism of SVT, whether it's AVRT or AVNRT. And if you have more V's than A's and the patient has a narrow or usual complex QRS, it can be one thing and one thing only, and that's junctional ectopic tachycardia. And we'll look at a few examples in a bit. However, if the patient has a wide QRS, which is wider than what his QRS looks like in sinus rhythm, right? And you have A's equal to V's, it can be the following. It can be SVT with aberrancy, meaning this patient can have SVT with a bundle branch block that developed during tachycardia. You can have something called antidromic AVRT, which is tachycardia going down a patient who has WPW or ventricular pre-excitation, or an atrial tachycardia with a bundle branch block. However, with a wide QRS, if you have V's more than A's, it can be one thing and one thing only, and that's ventricular tachycardia. So I hope this algorithm helps. So every time I look at an EKG, the first thing I look at, what is the QRS and what is the relationship of the P to the QRS or atrium to the ventricle? And then if you think about it that way, it makes it a lot simpler. So when a patient comes in some sort of tachyarrhythmia, and this is mostly whether it's in the emergency room or even in a clinic, right? Sometimes kids come in SVT to primary care clinics. The first and foremost thing is treat and stabilize congestive heart failure if the patient looks sick. Secondly, try to make a diagnosis. You can always give trivagal maneuvers and adenosine. Vagal maneuvers and adenosine is usually never the wrong answer except for one case, and I will show you that case later in the presentation. And once you make a diagnosis, whether it's by looking at the 12 lead or by doing certain maneuvers like a vagal maneuver or giving adenosine, you can think about antiarrhythmics. And finally, if the patient's unstable, you just have to convert the patient. Okay, so I hope all of you can see this. This is an echocardiogram clip of a baby who came in with SVT. So just to orient everyone, this is the left atrium, this is the right atrium, this is the right ventricle, this is the left ventricle. And I can tell you that this left ventricle looks very globular, it looks dilated, and the function is significantly depressed. So there is a term called tachycardia-induced cardiomyopathy. If a baby is in SVT for a prolonged period of time, and I'm saying hours, sometimes even days, over time, the ventricular function is affected. And that's what we sometimes see in these babies. And once you get them out of SVT, babies are resilient. They're remarkable. The function in the majority of the cases will recover. Okay, so we'll do this. I'll show you cases, and then there is the little poll link that is posted in the chat. So if everyone could log into through the link, and we'll try to see what we get. Okay, so this is a 2-month-old that presented to the emergency room with a fast heart rate. This is the EKG, or this is the strip that we had, and I can tell you this is pretty fast for the baby. So what do you guys think? Here is the poll. So feel free to put in your answers. And if you want, I can go back. Yep, there you go. All right, so I can see some folks answering already. I'll give this about 10 to 15 seconds. Looks like we're having a nice battle between SVT and sinus tach. It's impressive. I'm surprised nobody's paged EP yet, so that's good. All right, so why don't we end it there? So 56% said SVT mediated by an accessory pathway, and 44% said sinus tachycardia. So let's look at this strip again. That's a pretty fast heart rate for a 2-month-old baby. And I will tell you why that is SVT mediated by an accessory pathway and not sinus tachycardia. However, so when a patient comes in tachyarrhythmia, usual complex SVT or narrow complex SVT that we just talked about, there are a few steps that I do or a few steps we can use to manage this patient. Number one, if the patient is unstable, cardiovert the patient. There's no question. If the patient is stable, always try to get a rhythm strip. Gives us more data. Never wrong to try vagal maneuvers, and never wrong to try adenosine other than the one case I mentioned. And if the adenosine or vagal maneuvers is successful, you can consider a maintenance antiarrhythmic to keep them out of it. And of course, we're always happy to take them to the EP lab and ablate a tachycardia pathway when they are older, usually when they're greater than 15 to 20 kilograms. However, this is the important part. If adenosine is unsuccessful, examine the rhythm strip. What happened? Do you have subtle clues when you give adenosine? Big question. How much adenosine was given? Was the appropriate dose given? And how was it given? Was it given in an IV that's on the dorsum of the foot that is far away from the heart? Or was it given in an IV that is in the antecubital vein, which is closer to the heart? Was it followed with a 10 cc flush? These are questions that are important before we say adenosine did not work. And if truly you have clues on the strip that you had an adenosine defect, and we will talk about this, re-evaluate your diagnosis. So in this patient, this is the same strip we just looked at. If you notice pretty closely, right? So the heart rate's about, this is a fast heart rate. It's about 280 beats a minute. So unusual for this to be sinus tachycardia. So if you look very closely at my red arrows, you can actually see small P waves that are marching through or that are related to your QRS complexes. These are actually retrograde P waves, meaning electricity is going from the atrium to the ventricle, turning back up, going to the atrium, right here, coming back to the ventricle, atrium, ventricle, atrium. So you have a re-entry circuit right here. And guess what? You gave adenosine. Right here is when you see the effect, and boom, the tachycardia terminates. And this is now normal sinus rhythm. Note the difference in SVT and normal sinus rhythm at the end of the strip. So this is SVT mediated by an accessory pathway. It's a narrow or a usual complex tachycardia. So electricity is going down the AV node this way, turning back up the accessory pathway into the atrium, down the AV node, up the accessory pathway, and then you have a reentrant loop that goes round and round. So it's a narrow QRS tachycardia. And as we just looked at, P waves are often visible in greater than 1 EKG lead. Look at the early ST segment for retrograde P waves. And these reentrant tachycardias, as we already discussed, pretty sensitive to vagal maneuvers or adenosine. So once you have a diagnosis, you probably want to keep a 2-month-old baby who's been in a heart rate of 270 or 280 that you just got out of SVT, out of SVT. So you want to put them on an antiarrhythmic. And very briefly, you can do it either IV or PO. IV we reserve for babies that look sicker, who have some sort of congestive heart failure, who we don't want them to go back into SVT and who are also sick and just not able to tolerate PO. So IV drugs are classified based on something called the William Vaughan's classification of antiarrhythmics. And you can try procainamide, you can try esmolol, you can try amiodarone or sotalol. All of these are IV forms of drugs. And if the baby is otherwise healthy, has been in SVT for a few hours, the baby looks good, wants a bottle, you can just put them on an oral drug. So you have options of flecainide, digoxin, which I did not put up there, propranolol, or you can put them on amiodarone or sotalol. Typically, we reserve this for babies that have refractory SVT. Our first line oral drug is usually just propranolol. If propranolol does not, it's a very safe drug. We've been using it for years. The most common side effect is hypoglycemia. However, it's mostly in preemie babies and babies who are not feeding well. And if propranolol does not work, then we escalate to either flecainide or sotalol. All right. Case number 2. So this is a 10-day-old post-op patient who had total anomalous pulmonary venous connections, underwent repair. It's post-op day 1. The baby's in the cardiac ICU, and we are called about this baby in a fast heart rate. So I'm going to give you a second to examine this strip before we go to our live poll. All right. So what do you guys think this is? And I just want to say option E is usually the right option, if anyone was wondering. All right, we're going to give this 10 seconds before we move on. Okay, so atrial flutter seems to be, yes, somebody is yelling at EP. Thank you very much. I was waiting for someone to yell at EP. So now that YP has been yelled at and we have an overwhelming majority of people who think this is atrial flutter, let's move on. Yeah, absolutely. This is atrial flutter and we'll talk about it, talk about why. So again, same exact algorithm. And I'm showing this again just to hammer it in place. Same exact algorithm for a patient in usual complex, narrow complex tachycardia. Unstable, cardiovert. Otherwise, rhythm strip, rhythm strip, rhythm strip. Always try vagal maneuvers, adenosine, except one case. If it's successful, that's what we talked about, antiarrhythmics, ablation when older. If it's unsuccessful, examine why it's unsuccessful, look for clues, and make sure adenosine was given the right way. So let's see what happened when this patient got adenosine. And this is the strip when this patient got adenosine. So adenosine effect started right here, and this is what happened, and the patient slowly went back into the same tachycardia. So would you say adenosine was unsuccessful here, or would you say adenosine did exactly what it was supposed to, and it made a diagnosis? So I want to impress upon you that adenosine is not only therapeutic, it's also remarkably diagnostic. If you look at this strip very closely, right here, between the QRSs, you have two P waves where my red arrows are. So this is a patient that's in 2-to-1 atrial flutter. And when you give adenosine to a patient in atrial flutter, so atrial flutter is a reentrant circuit, we talked about it within the atrium. Adenosine blocks your AV nodes right at the junction. This is where adenosine acts upon. It usually does nothing to the atrium. So when you give adenosine and it blocks the AV node, all of the flutter waves that were going down to the ventricle can now no longer go down to the ventricle. So what happens is you can actually see what's going on in the atrium much, much clearer. And if you look back, give adenosine, your ventricular rate slowed down, but look, the atrium, you can see clear flutter waves. Classic example of adenosine being a diagnostic drug and not therapeutic in this case. But once you have made the diagnosis, you know what the mechanism is. And this has significant implications for treatment compared to the reentrant tachycardia we just looked at. So once you have a patient in atrial flutter, you have three options. You can either rate control, meaning control the ventricular rate, meaning control how fast those flutter waves are going down to the ventricle. You can try to cardiovert them chemically, meaning using a drug, or if the patient has pacing wires, you can try to pace terminate them. Remember, it's still a reentrant circuit. Or if the patient's unstable, you have to cardiovert. So rate control is usually accomplished by either calcium channel blockers or beta blockers. Chemical cardioversion usually accomplished by IV drugs such as procainamide, amiodarone, or sotalol. And then again, if you have pacing wires, usually these patients post-op have pacing wires. You can use that to pace terminate the tachycardia. And again, if the patient's unstable or if none of this is working, just go ahead and synchronize cardiovert this patient, and that will be successful. Okay, so this is a fun one. So this is a 1 month old with fast heart rate in the NICU. And we were called by the NICU because of a fast heart rate. So this EKG obtained on this patient on the 30th of August, read by me. I called it sinus tachycardia with left axis deviation. And before you think I don't know what I'm talking about, I really want to explain why I called it sinus tach. So if you look at P waves in leads 1, AVF, and 3, they are all upright. So you have a normal P wave axis in this patient. And then the way I think about axis is very simply, you look at leads 1 and AVF. If lead 1 QRS is positive and AVF is down, that's left axis deviation, which is why I called it sinus tach with left axis deviation. All right, very good. The next morning, the next morning, Dr. Johnsruth said, no, 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 this is ectopic atrial tachycardia and this is an abnormal ECG. And this is why he called it ectopic atrial tachycardia. So look at the P waves now. Lead 1 is still upright. However, contrast to the prior EKG, lead 3, it was inverted. Lead AVF, that's inverted. And I completely agree. This is an ectopic atrial tachycardia. So what happened? Did the baby go from a sinus tach with left axis deviation at a heart rate of 218 to an ectopic atrial tach at a heart rate of exactly the similar heart rate at 218? That sounds a little fishy. And so when we looked at telemetry, what we found was that the heart rate was fixed and was fixed at 210. And that does not go along with sinus tach. Sinus tach, you're allowed to be fast, but there is usual heart rate variability. So in this case, what is the correct diagnosis? And you can get your poll phones out again. Is it sinus tach, as I said? Is it ectopic atrial tach by Dr. John's route? Both are correct, both are wrong. And or do you think this is why we need a third EP doc to break the tie? Perfect. Yes, thank you to whoever answered that. All right, so there's 5 more seconds. Pretty good battle between both are correct and both are wrong. All right, guys, so I'm gonna move on. So in this case, this is one of the cases where both of us were correct, and I'll show you why. So this patient, the first EKG that we had, that I call sinus tach, actually had a left arm, left leg lead reversal. So what happens is, instead of putting the left arm lead on the left arm, it went on the left leg, and the left leg lead went on the left arm. And the way you know that is these are certain things that happen when you have left arm, left leg lead reversal. Oh, by the way, this is from Life in the Fast Lane. Most of my EP knowledge is from Life in the Fast Lane. So it's a great resource for if you want to look at lead reversal. So lead 3 becomes inverted, leads 1 and 2 switch places, and leads AVL and AVF switch places. Hang on to that thought for a second. This is the EKG in normal sinus rhythm after we gave the patient a beta blocker. I read it, sinus rhythm, baseline artifact, otherwise normal. So look at lead AVF. That's all I want you to look at. Upright P wave, upright P wave, upright QRS. Compare that to the first EKG that we just looked at. Upright P wave, but the QRS is inverted and AVL's QRS is upright. So you know that this is lead reversal. However, there is absolutely no way of knowing this without getting an EKG in sinus rhythm with proper lead placement. This is a diagnosis in retrospect. This is a diagnosis in hindsight once I confirm that this is what his axis really looks like. Because otherwise, if his QRS was still negative, he would have still had left axis deviation. So the takeaway from this case is an EKG is only a spot diagnosis. It gives you a diagnosis for a few seconds. It is so important to go and look at telemetry, to look at trends, to go and look at the baby and see, is the heart rate fixed? Is there any variability? What else is going on with the patient? Every clue that you get helps you remarkably towards making a diagnosis. So this was an ectopic atrial tachycardia. Again, exact same algorithm that we use for our reentrant and for our patient in atrial flutter. So as a side, what do you think would happen if you gave this patient adenosine? Most of the time. So again, adenosine blocks the AV node, usually would not affect the atrium. So you would see the ectopic atrial tachycardia march along just like you would have seen in atrial flutter. So ectopic atrial tach is an ectopic automatic focus within the atrium. As I said, it is a focus with a mind of its own. It's usually faster than the sinus rate, and it has its bizarre mind. It goes on at its own rate. And the biggest clue is you have to look for a different P wave axis compared to normal sinus rhythm. Treatment options are exactly similar to how we described for reentrant tachycardias. You can treat it IV or PO. IV drugs are procainamide, esmolol, amiodarone, or sotalol, and then oral drugs are flecainide, propranolol, amiodarone, or sotalol. It again depends on a little bit on how the patient is doing. Is the baby NPO? Does the baby have other comorbidities? Does the baby, for example, have neck and cannot tolerate anything PO? In which case you would do an IV drug. Otherwise, it's totally reasonable to put a baby on an oral drug. This baby we put on propranolol, and remarkably, after one dose, the patient came out of ectopic atrial tach and was in normal sinus rhythm. Okay, so this is a 10-day-old post-op patient, post-VSD repair that's in the cardiac ICU. We were called about a fast heart rate. couple of things before we move on. I will tell you the QRS complexes, even though they look a little wide, are usual complex for this patient. Remember we talked about patient with VSD repair can have a bundle branch. This is how his QRS looks in sinus rhythm. So this is narrow or usual complex for the patient. This is an atrial wire tracing. So this is a little trick that EP and cardiac ICU docs have. Postoperatively, because of the atrial scarring, it's sometimes hard to see P waves. So the surgeons will often place pacing wires on the atrium, and we use those pacing wires to amplify and see what's happening in the atrium. So I have marked out P waves with my red arrows. So these sharp little spikes are your P waves. Everything else are QRSs. And this is a zoomed up version of it. So that's a P wave, that's a P wave, QRS, 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 QRS. Okay, perfect. So now that we know that in this strip there are 4 QRSs and 2 P waves, what is the diagnosis? And remember, this is a narrow or usual complex tachycardia for this patient. All right, 100% with junctional tachycardia. We'll give this 5 more seconds. All right, I think everyone agrees this is jet. Perfect. Yep, this is junctional tachycardia. So if we go back to our simplified algorithm for EKG analysis with tachycardia, we said this patient has narrow or usual complex QRS. And on the zoomed up snippet, I showed you that this patient had more QRSs than P waves or more Vs than As. And that can be one thing and one thing only. So this is junctional ectopic tachycardia. This is how I think about every single EKG I look at. This is how I think about every single time I look at telemetry. Okay, so junctional tachycardia is an automatic focus. It's an automatic tachycardia that's at the AV junction. It is very, very common post certain cardiac surgeries, especially surgeries like AV canal repair, VSD repair, and tetralogy of Fallot repair. There is a whole algorithm that we follow in the cardiac ICU for managing these patients, and that involves diagnosing it with atrial EKGs, 12-lead EKGs like we talked about, controlling their temperature, paralyzing, sedating them, pacing them, and then using antiarrhythmic. I won't go into much details, but just know there is a whole algorithm that the whole team follows to manage these patients on an inpatient basis. This is not something that you see outpatient. This is mostly an inpatient problem. Okay, so we talked about narrow or usual complex tachycardias. Let's get to the fun part. Let's get to the tachycardias that cause me to hyperventilate into a paper bag. So these are wide QRS tachycardias. So wide QRS, again, just as a refresher, if you have P's equal to QRSs, could be SVT with aberrancy. Surprisingly, most common cause of wide QRS tachycardia is in pediatric patients, not a 40-year-old adult who probably has VT, antidromic AVRT, and then atrial tachycardia with aberrancy. But if you have a wide QRS with more V's than A's, it can be one thing and one thing only, and that's ventricular tach. All right. This is, again, a real case. So this is scary. 8-year-old in the emergency room with palpitations. Okay. I'm going to give you a second to look at this strip before we move on to the poll. All right, here we go. What is the diagnosis? Is it ventricular tach? Is it SVT with aberrancy? Is it pre-excited atrial fibrillation, whatever that is? Is it junctional tach? Or I don't know what is going on. So 87% think this is VT, 7% think this is pre-excited atrial fibrillation, and 7% chose option E, which is a reasonable option in this case. All right, 5 more seconds and we'll move on. Okay, so we have a winner. It looks like 88% think this is VT. In this case, this is not actually VT, and I'll show you why. Okay, so wide complex SVT. Biggest thing I want to impress upon you on this strip, look at the R to R intervals, meaning the intervals from the one QRS to the next. That is pretty irregular, right? There is no pattern to your R to R intervals. These two QRSs are bunched up together. This is even closer. This is longer. This takes somewhere in between. It's an irregular R to R interval. So wide complex SVT, get a rhythm strip like we did, irregular R to R intervals. You have to ask yourself the question, is this a patient in atrial fibrillation, and does this patient have WPW at baseline? It helps if you have a prior EKG, but not always. Patients usually walk in for the first time with palpitations and you don't know what's happening, and you see that, you see irregular R to R intervals, you have to ask yourself that question. This is that one case where you never, 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 ever give adenosine, because I will show you what happens when you give adenosine. So if this patient's unstable, you cardiovert. If this patient's stable in SVT, the only drug that is reasonable to try is procainamide in an IV form. So let's look at what happens if you give adenosine. This is a real strip, guys. This patient came into the ED, got adenosine. This is from my previous training. This patient got adenosine, and that's what happened. Real tracing, that's what ventricular fibrillation looks like. When this patient got defibrillated, now this is in sinus rhythm. Look here at my arrow, that's a delta wave. That's a delta wave, delta wave, delta wave. So this patient has WPW, and I'll explain to you what just happened. So this patient, so this is what WPW looks like. This is your normal AV nodal conduction. This is an accessory pathway that allows electricity to bypass your AV node and go down to the ventricles. So it pre-excites the ventricle. So you get a short PR, you get a wideish QRS because the activation is not through your normal conduction system, and you get a delta wave as shown here. By the way, this is a picture of doctors Wolf, Parkinson, and White, the three physicians after whom WPW is named after. So when such a patient who has WPW goes into atrial fibrillation, meaning the atrium is going at 300 beats a minute, all of those beats can go down this accessory pathway. And because at baseline the QRS looks wide, this is going to look like a wide QRS tachycardia. The R2Rs will be irregular because AFib is usually an irregularly irregular rhythm. And if you give adenosine to this patient, what you will do is block the AV node and force everything to go down the pathway, because adenosine does not block the pathway. You'll force everything to go down the pathway, and all 400 beats will go down to the ventricle, and that'll cause the ventricle to fibrillate. And that's exactly what we saw. So irregular R2R wide QRS tachycardia, never, 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 ever adenosine. Okay. All right. This is the class 1 or recommendations for guidelines of patients with WPW. I do not want you to remember this. When you see a patient with WPW, the questions you should be asking yourselves are, does the patient have femoral veins? If not, does the patient have an internal jugular vein? If not, does the patient have a liver? And the reason I say this is if the patient has WPW, there is a small risk of sudden cardiac death in these patients. So we will usually take them to the EP lab and try to ablate this pathway. And the ways we do that are femoral venous access, if not internal jugular venous access. Finally, if none of these, we'll try transhepatic access. So if the patient has veins somewhere, just refer them to us and we'll take care of it. Okay, another real tracing. 23-year-old in the emergency room with quote unquote seizures, passing out, waking up, absent-like seizures till somebody got an EKG and put them on telemetry, and this was her rhythm. Wide complex for her. This is not narrow complex for her. We won't do a poll on this one, but I want to show you how to manage wide complex SVT with regular R2R intervals. So contrast this with what we just saw previously. The QRS to QRS intervals are pretty standard or pretty stable in this case. So wide complex rhythm strip, regular R2R intervals. Look at your VA relationship, meaning more V's than A's or more A's than V's. If you have more V's than A's, it can be one thing and one thing only. That's ventricular tachycardia. If the patient's unstable, defibrillate. If the patient is stable, you can try medicines to get them out of VT. This patient was otherwise stable in between her episodes of seizures. So we said, let's try amiodarone, otherwise we'll just defibrillate. And after the second bolus of amiodarone, she converted to normal sinus rhythm. However, if you have V's equal to A's, it can be VT or it can be SVT with a bundle branch block. It is not wrong to try adenosine in this case. Remember, it's not an irregular R2R interval tachycardia. And then your treatment is going to be based on response. If it's SVT, adenosine will usually terminate it. If it's VT, remember adenosine works at the AV node junction, does not affect the ventricle will keep on going, and you won't affect the tachycardia. So V is equal to A's, it would have been reasonable to try adenosine in this case. Okay. So we talked a lot about tachyarrhythmias, hard to ignore bradyarrhythmias. So let's talk about a simplified algorithm for a patient with bradycardia. If you have a patient that's in bradycardia and has A's equal to V's, it could be sinus bradycardia. Now I've put first degree AV block, and I will say first degree AV block is not a cause of bradycardia, but it's a type of AV block that comes up. So I've just put it up there. But if the patient's bradycardic and A is equal to V's, it's usually sinus bradycardia. However, if you have more A's than V's, it could be one of two things. So it could be premature atrial contractions that are blocked, meaning that are not going out to the ventricle. Most common cause of bradycardia in newborn babies in the newborn nursery, quite remarkable. Or you could be dealing with something more nefarious in terms of second or advanced or third degree AV block. Okay, so this is a 7-month-old that recently showed up in our emergency room with a slow heart rate. And the way this was picked up is because she came to the emergency room with a viral infection, and the emergency room doctor listened to her heart rate and thought it was slow for a baby, so obtained an EKG. And I have pointed out your P waves or your atrial activity with the red arrows. The heart rate for this baby, as you can see, is about 75 beats a minute, which is pretty slow for a 7-month-old baby. Okay, so what type of heart block is this? Is this first degree? Is this second degree type 1, second degree type 2? Is this third degree, or option E? Again, option E is never the wrong answer. Okay, I'll give this 5 more seconds. Looks like 100% of people think this is third degree or complete heart block. Everybody loves EKGs after this, so I am so happy. Okay, we'll give it 5 more seconds since people are still answering. Okay, so 83% think this is complete heart block, 8% think this is second degree type 2, and 8% think this is first degree heart block. So this is complete heart block. So the way you know this is complete heart block is if you look through this whole strip, the P waves and the QRSs, they don't have a relationship. Meaning the P waves have a mind of their own and the QRSs have a mind of their own. This P wave, they're straight up marching through. And you can see there is no constant PR interval. So look at this PR interval, look at this PR interval, there's a PR interval. There is no relationship between the P's and the QRSs, meaning there is dissociation between the atrium and the ventricle. And so this is a case of complete heart block. If this was first degree, every P wave would go down to every QRS. However, you would just have a longer PR interval. However, you would not have a dropped beat. Here, they have a mind of the atrium and ventricle are just two separate minds. So this is complete heart block. And why do we care about complete heart block? This is the reason. There is good data that if babies have long pauses with complete heart block, if they have complex ectopy, they can actually have pause-mediated VT and VFib. So that's why we want to treat babies, or that's why we want to get to know about these babies with complete heart block at a pretty early stage. And again, there's this thing about natural selection. The 7-month-old baby, thankfully, had a good escape rate in the 70s to 80s. If her escape rate was slower, meaning her ventricle decided to only go at 40 beats a minute, she would have probably shown up much sicker, much earlier in the emergency room, and we would have picked it up sooner. Contrast that EKG with this EKG of a patient of a 16-year-old. This is nothing but sinus bradycardia. So the heart rate is pretty slow. It's 40 beats per minute, but every P wave marked by my red arrows goes to every QRS, and the PR interval is pretty constant. So this is sinus bradycardia. This is good relationship or a normal relationship between the atrium and the ventricle. Should this patient get a pacemaker? Big question. We get called about this, right? Patient's bradycardic, heart rate sitting in the 39, 35, 32. The indication for a pacemaker in a patient with sinus bradycardia is only if they are symptomatic, meaning if they are having dizziness or syncope associated with bradycardia. That's an indication for a pacemaker. If this patient's walking around just fine, is an athlete, is a football player, sleeping at night and the heart rate is 35, doesn't matter. Gonna ignore it every single time. However, the only indication for a pacemaker is symptomatic sinus bradycardia, and that's a key term that we have to remember. Okay, so for that baby, does every baby with a complete heart block get a pacemaker? And the answer is probably yes. And the answer is yes, eventually they will need a pacemaker, but they may not need a pacemaker right at the moment. And this baby we sent home from the emergency room, and these are, I only want to highlight the class 1 indications for pacemaker placement in congenital complete heart block. So symptomatic bradycardia, we talked about it. So if this baby came in sick, was not looking well, yes, we would put in a pacemaker. If this patient's QRS or ventricular escape was a wide QRS, if this patient was having a lot of complex ectopy, meaning PVCs or long pauses, or on echo, if the ventricular function was low, we would put in a pacemaker. This 7-month-old did not have any of them. And finally, people say that if the average mean resting ventricular rate is less than 50, some people will put in a pacemaker. Personally, and I know a few other EPs who think that way, I trust this rate criteria probably the least, and we look at other things. How is the baby doing? How does the function look on echo? Is the baby having long pauses or PVCs? All right. So that's all I have for you today. Thank you so much for listening. And this is my email, and that's my cell phone number. I'm serious. Feel free to call, text, or email me with any questions that you have. It's been an absolute pleasure being here. I'm happy to help or try to help in any way I can. However, if you want real answers to your EP questions, that's who I would reach out to. That's Dr. Johnsrud. That's my colleague. And I just want to say it's been an absolute pleasure working with him. And so we are both here to assist with your EP rhythm questions, and we are always here. So feel free to shoot a text, call, just to say hi, or just send me an EKG anytime. Okay? Well, thank you so much. Thanks everyone for your attention. It's been a pleasure. Are there any questions?
All right, if no one has any questions, thanks Dr. Dasgupta again, and everyone have a great Friday.
Thank you so much. Have a good day.